Good morning, good afternoon, good evening, colleagues. I'm Neena Valecha, President of National Academy of Vector-Borne Diseases and also Chair of APMEN Vivex Working Group. Formerly, I was at WHO, Southeast Asia region. It's my privilege to welcome you to this webinar today, which is Malaria Global Trends, Regional Insights, and Country Action Plans. And this is being held in commemoration of World Malaria Day 2026. I must add that this webinar aligns with World Malaria Day theme of 2026, which is driven to end malaria. Now we can and now we must, which is a shared rallying cry for renewed commitment and collective action towards malaria elimination. This webinar is being hosted by National Academy of Vector-Borne Diseases, which is a premier body dedicated to fostering scientific research, education, and public health initiatives related to vector-borne diseases. And this was established with a vision of creating a healthier community free from burden of these diseases. And NAVBD brings together leading experts, researchers, policymakers, and the mission is to advance knowledge, develop innovative tech strategies, and disseminate critical information by way of holding workshops, conferences, and now this is another medium like webinars. And this can help in combating diseases transmitted by vectors such as mosquitoes, ticks, and flies. The webinar is being co-hosted by Asia Pacific Malaria Elimination Network, APMEN, which is hosted by APLAMA, which is Asia Pacific Leaders Malaria Alliance. And APMEN is a country-led regional network bringing together 22 Asia Pacific countries and over 50 partner institutions to accelerate and sustain malaria elimination across the region. Now, today on this World Malaria Day, we stand at historic crossroads, and under the global banner driven to end malaria, now we can, now we must, we are reminded that for the first time, ending the disease in our lifetime is a real possibility. Of course, there are many challenges. Many countries have been certified malaria free, but there is the situation is also stalled in some countries. And also, we would like to today debate on global trends, regional shifts and also to the country action plan, like India's goal of zero indigenous cases by 2027. Now we have new tools also, and they are like vaccines which are protecting millions of children. The blueprint for malaria elimination is now clearer, and let us discuss how to turn this blueprint into the malaria free reality. And our distinguished panel today from global, regional, and country, they will share their experience and perspectives. So I would like to also give some housekeeping announcements. Can I have the next slide, please? So audio and video of attendees will be disabled, but please give your comments in the chat box and Q&A box. And the three presentations we'll have, as you must have seen in the flyer, and we'll have question answer session at the end. And please type your questions in Q&A box during presentations, and you may even get speakers are free to answer them in the chat box as well as we go along, or otherwise we'll try to cover most of them at the end of all presentations. Please also write the speaker's name to whom you want to address that question. And at the end, we'll have a quick Zoom poll. And I hope I'll request the first speaker, Andrea, for sharing giving his presentation. Dr. Andrea is heading the malaria and NTD unit at WHO. Diagnosis, medicines, and resistance of head of diagnosis, medicine, and resistance at WHO Malaria and Neglected Tropical Diseases Unit, Geneva, and he oversees policy development regarding anti-malarial medicines, including pharmacovigilance, and he has played a key role in developing WHO guidelines on malaria treatment and quality standards for malaria diagnostics. And over to you, Dr. Andrea, for the global trends, please.
Thank you very much. And please allow me to maybe have my presentation. This is not the correct one. thank you and the meeting organizer, particularly the National Academy of Vector-Borne Diseases and APMEN for inviting me to this important webinar. I would like to address the fighting emerging malaria threats and give the global perspective. If I may have, please, the first slide. And if we go to the next one, and it's interesting to look at what are the major concerns which can affect the trajectory of malaria response over the next 5 years. I try to summarize in very broad terms what we see as really risks for a combination of factors which can actually, we can call a perfect storm. The first one is clearly the financial situation. We see a major reduction in resources, not only from ODA assistance, from international funding agencies, the Global Fund, Gavi, and we are all concerned about the need and the challenges with the increasing of domestic funds to cover actually the massive financial needs to fight malaria. We have fragile health systems, and we don't have and I'm talking a global perspective, and this may not apply to countries in your region, but there is generally problems in sustaining management capacity at the national malaria control programs, and the surveillance system are weakened, especially when it comes to funding restrictions. Often the surveillance is one of the first arms which gets some reduction in terms of investments. There is a high level of humanitarian crisis due to displacements of a massive population. We have in the African region more than 100 million people which are affected by complex emergencies and also affected by malaria epidemics. And to all this, we also have the malaria-specific biological threats that we will present at this meeting. So basically, if we look at the next 5 years, we have a combination of factors which can actually increase and create a major risk for the malaria burden. Next slide, please. Now, if we look at the trend, this is not just since 2025. This is unfortunately a situation which we have seen since 2016. After the massive call for increased investment actions and major international attention to the Millennium Development Goals, the situation has really not progressed in line with what were the global targets. There was, at the World Health Assembly in 2016, the agreement to reduce by 2030 up to 90% malaria death, malaria cases. And if you look where we are here, just by 2025, we are threefold higher in terms of cases and deaths compared to where we should be. So we are massively off target in terms of the projected, let's say, trajectories that were anticipated or committed to in 2016. Next slide. And one of the key major problems is the funding shortfall. At the moment, we see that we are only approximately at 40% of the level of funding that we should have to achieve the global targets. And if we look at the trends over the years, you can see that since 2010, the situation has been basically stable. Why? We would have needed more funding, probably more than the double of the funding which has been committed. And here you see in color codes the different sources. You see in blue the basically global fund support. If you see in yellow, orange, so it's more an orange, it's the US government. And the US government in the global fund is also a major contributor. We have agreed the domestic fund, and it has been progressively increasing, now representing 44% of the global fund. But we are all concerned, particularly with the US government, now change in investment strategies, in the international commitments, and the potential implications on for malaria control in many countries, not only in the African regions. So next slide. One of the major threats that we foresee is related to anti-malaria drug resistance. And we all remember 25 years ago, approximately, the major disaster related to chloroquine and NSP resistance. At that time, the estimated increase of mortality was sevenfold attributed to chloroquine resistance only. And what we know is that unfortunately the ACTs are at the moment threatened by the emergence of partial artemisinin resistance, initially in the GMS, but now very clearly present in selected countries in South America and in increasing number of countries in the African region. Here in green is those where it is definitely confirmed. We should say that actually even Ethiopia should be green colored here in this map because the data are really emerging also for this country. So in this region, the pressure created by artemether lumefantrine is massive. It's more than 80% of the drugs in the public sector and also in the private sector are this single compound. And it's very basically a major risk because even the new compounds that are under development contain lumefantrine, whether it's the triple combination, whether it is ganaplacide lumefantrine, that is a precious companion of the artemisinin that at the moment is under tremendous drug pressure in the African region. Next slide. There are improvements, and definitely one thing which is very good is that access to both the diagnostics and ACTs has increased over the year. And this color basically graph is the proportion of children under 5 in Africa, which has been detected through household surveys. So it's really the actual coverage, and it has been up to 68%, two-thirds of those which seek any form of a caretaker, they get an ACT for treatment, which is very good. But again, one of the major, at the moment, threats in terms of drug pressure, as I said, is that reliance on a single dominant ACTs, all containing, again, lumefantrine. Next slide. To respond to drug resistance, the response needs to address system weakness, and most of it really depends on having quality of care for malaria in the health services, including the private sector, which is highly unregulated. And in this map, again, applicable to Africa, but I'm 100% sure applies to all malaria endemic countries. A majority of malaria patients, they seek treatment first in the private sector. Recently, I was in Afghanistan, and even in Afghanistan, with relatively little malaria, more than, I would say, two-thirds, 60% of patients, they seek treatment in the private sector for malaria. And the strategy that has been put in place definitely sees an important need to address all health components of the health system, from the community to the primary health care to the private sector, should be part of, again, of a good access to diagnostics and quality of care. The experience in the GMS have also shown that the drug resistance may be coming from a shared threat also a common agenda, and that's where the elimination of partial autoimmune resistance has becoming the major force for driving down transmission. As shown in the next slide. The next slide shows trends from several countries, and especially here, very attractive the situation in Cambodia, Laos, Vietnam, where the number of cases has been significantly decreased. And different, again, situation in Myanmar, which also shows that how progress in malaria is fragile, and unfortunately, problems of conflicts, civil unrest have an immediate repercussion on the effectiveness of the malaria control program. So that is, again, biological threats which combine with human risk and crisis to actually fuel, again, the resurgence of malaria in many settings. Next slide. In terms of the biological threats that we face, an important one is the HRP2 gene deletions in falciparum malaria. Unfortunately, this protein is not essential to the survival of the parasite. So once it is established, it stays, it remains. And we are seeing massive problems in South America, but now in the Horn of Africa spreading. And from different publications, it is possible to derive some estimated countrywide prevalence, but this is very imprecise. We know that even in India, there are areas where actually prevalence has been identified relatively high. And when WHO recommends when it is exceed 5%, then it's time to replace HRP2 detecting RDTs with other type of RDTs. And the next slide shows actually some good news we want to share. And that just a few days ago, the WHO pre-qualification program has approved some specific RDTs manufactured by Rapigen, which are targeting the PF-PLDH antigens instead of HRP2. And this is an antigen and is an enzyme which is essential for the parasite survival. And luckily, we will not see, let's say, deletions in the gene which code for this protein. So very good news. And very good also perspective from information we have on the production capacity of this company. So at least for one of the biological threats, this is one of the tools that may help countries moving forward. Already it was approved by the Global Fund procurement, but the pre-qualification gives an additional strong basis for public sector procurement. Next slide. If we look at other biological threats, this is not new certainly in India and the region and the Embro region, but is new in the African region, is the invasion of Anopheles stephensi, which, as you know, is very well adapted to the urban settings and has been unfortunately responsible for a massive resurgence of malaria in the Horn of Africa, and very difficult to control with the vector control approaches of today. Next slide. Still on the biological threats, we have a major problem with insecticide resistance. We put pyrethroids here because of their use in the long-lasting nets, but clearly the insecticide is a major issue affecting also other insecticides used for indoor residual spraying. On the good side, again, in terms of what is being done for counteracting pyrethroid resistance, is the increasing role of dual active ingredient nets, especially the chlorphenapyr nets and the PBO nets, which now represents more than 80% of the ITNs which are procured and distributed by countries. And very good that the price for these alternative ITNs has become now very comparable to the pyrethroid-only nets. So again, on the opportunities for now better tools to fight biological threats. Next slide. We have other interventions which are being deployed for chemoprevention, and these are all, I would say, mainly for areas where you have moderate to high transmission, so that when the prevalence is higher than 10% of malaria infections in children, so may not apply to many places in the Asian settings, but we have seasonal malaria chemoprevention here now covering in Africa more than 50 million people per year, which is very good in all these areas color-coded. We have more recently introduced the perennial malaria prevention, which is given together with the vaccination schedules in children under 2 years of age. And then we have also the intermittent preventive treatment of malaria in pregnancy, which is still not reaching the targets we want, but showing some increase progressively every year. Next slide will give some data on the vaccine, which was mentioned by Dr. Valencia. It's a very important new tool. We have two vaccines, again for moderate to high transmission areas at the moment, which have been deployed in over 10 million doses, covering over 2 million children in the African settings. Still, the, let's say, coverage is low, but it's a very recent intervention, which is now prone to larger utilization. Some trials are ongoing in the Gambia for all population, and also looking its impact on transmission settings in relatively low settings. So maybe there could be applications and use beyond just children and areas of intense transmission. Next slide. I'm just recapping here the major threats in terms of funding. There has been some estimates that a full drop in support from just the bilateral support of USAID will lead to an excess of 15 million cases and more than 100,000 deaths per year. And definitely what we know that any time that the efforts are reduced, malaria will rebound. And that's the major threat at the moment. There is definitely a global disruption in terms of international support, not only for malaria, but unfortunately for Gavi as well. And we have seen as a result, and already documented from many countries, the stockouts, problems in distributions, problems in campaigns, which are being delayed. Now, in some situations, there are mitigation strategies already implemented by partners, but there is this, let's say, interruption of the USAID funding, and the conditionalities related to the new way of funding through the State Department are definitely pointing to an area where we will expect definitely consequence. Next slide will give us, this is the last slide, just to say some of the political, let's say, strong move which we have seen. It's essential that there is a national political commitment to end malaria. And recently in Yaoundé, the 11 high-burden countries of Africa have committed to accelerate the reduction of malaria mortality, and under the commitment that nobody should die of malaria with the tools available. And certainly, if that's possible in the high-burden African countries, is certainly feasible much more in all other regions in the world. There are multi-stakeholder efforts. One is the Big Push initiative, which calls for intervention at multiple levels, global, regional, and country level. And also the increased, let's say, translation of new tools in implementation. There is a strong call from all corners of the role of the communities and the new roles and system models for the governance, where actually is the country's stewardship, which will be now important, essential in moving forward the agenda, not only in countries in the advanced phase of elimination, but in all countries also with very high burden of malaria. And with this one is my last time. I want to thank you for your kind attention. Thank you.
Thank you, Andrea, for the sharing your valuable insights. And definitely, as you mentioned, funding issue is a very big challenge in the present scenario, and also the other aspects which you have mentioned. But rightly so, that with having so many tools and the diagnosis and treatment tools available, you are right, nobody should at least die of malaria, and we should be able to, and with the many countries showing elimination, we should be trying to work in that direction so that we have malaria elimination as per the targets. So we will have the questions, Andrea, at the end. So now we move to our next speaker, who is Dr. Risinta Premaratne, and he's a distinguished public health professional, and he serves as presently as regional advisor in WHO Southeast Asia region, and his area of expertise is epidemiology and surveillance. And we know prior to this he played a pivotal role in Sri Lanka as in the Ministry of Health, and when Sri Lanka achieved malaria elimination, and now his expertise is really valuable in for Southeast Asia region. Over to you, Risinta.
Thank you so much, Dr. Nina. In fact, this presentation was to be done by Dr. Suman Rijal, my director of the Department of Health Promotion, Disease Prevention and Control of WHO Southeast Asia Regional Office. But then, unfortunately, he's not well. So, therefore, I had to, as the regional advisor for malaria, I had to chip in. So, thank you so much. In fact, can I is my are my slides shared now?
Yes, I can see the slide.
Okay, wonderful. Thank you so much. So, good morning, good afternoon, and good evening, depending on where you are joining from. So, let me first of all thank the NAVBD and APMEN for organizing this webinar to commemorate the World Malaria Day 2026. So, my task is for the next 15 minutes, I'll take you through what the data tells about malaria elimination in our region, WHO Southeast Asia region, a story of achievement, but also one of a growing risk. And therefore, let me walk you through that. So, uh, okay, so this is kind of extracted from the global malaria slide deck, which was shown by Andrea, and then basically it's a complete copy of what he showed. Just to reiterate the fact, because I'm going to make a comparison here, that's why I wanted to show this to say that at the global level, the progress towards the key GTS targets are off track. Just to show that, in contrast to what we see. Or what we observe in Southeast Asia region, you would see that in spite of being the second largest contributor to the global malaria burden, the Southeast Asia region has shown the largest reduction among all regions in the recent years. And so it's basically as a result, it's the only WHO region that reached the Global Technical Strategy 2020 targets, as well as moving towards achieving 2025 targets, and also are likely to be achieving the 2030 targets as well. But at the same time, I want to show you one particular point here. You will see in this blue line, there is the malaria morbidity, the case, the burden has kind of plateaued in our region. And then you would see, in fact, there is an uptick over there. And then starting from this, the last year, we could see that probably whether we are going to miss our target of 2030 is also a question when we look at the projections. It appears like we are not exactly in line with their expectations. Therefore, in a way, we are at a crossroads as the region. So although we can be happy of all the achievements we have gained in the past, but we are at a stage where probably things are getting reversed as well. All the good things that we can talk about, Maldives and Sri Lanka, malaria-free Timor-Leste joined the club. So out of the 10 countries we have in the region, now only seven are endemic. Out of that, even Bhutan is now malaria-free for the past more than 3 years now, and probably WHO will be assisting them to get prepared for the WHO certification this year. When it comes to the other countries in the region, we have, of course, which were there in the E2025 club earlier: Bhutan, Nepal, Korea, DPR Korea, and Thailand. So Bhutan, as I said, has all achieved it. Nepal is closely following, and they have all for the past so many years they have been having the number of cases have been less than 50 cases. Korea, DPR Korea. So that they were pretty close when we were looking at it before 2020, but things have drastically changed over time. And then Thailand, of course, we know what is happening right now in Myanmar, the civil or the conflict situation in Myanmar, which has really increased the malaria cases tenfold there, and then also has spilled over all the cases that have been spilled over to the other side of the border in Thailand, which has really increased their numbers, kind of diminishing their probability of achieving malaria elimination. Their targets were pretty much achievable when before the conflict situation started. However, now of course they will have to readjust all their targets because of the spillover of all those cases. And then Thailand
Dr. Zinta, can you hear me, Dr. Ford?
We can
I
hear
think
you,
Dr.
Doctor.
Rasina has some connection problem.
Oh, from Dr. Zinta side. Okay.
Yes.
Okay. We'll just wait for a few seconds.
Dr. Nina, would you like to proceed to the next speaker?
He is connected. He is connecting. He didn't know
Okay.
he's offline. So maybe while we are waiting, is it okay? We can have one or two questions which were addressed to Dr. Andrea. I think is Dr. Andrea. Is that fine?
I'm okay. I think one I replied online in writing already was around the private sector. And
Okay. Okay. So I think one very of course that is very important point, but the other one which I observed was that which is also very relevant, that countries do have other priorities. So if they have many other issues, and that we see many times, like in transmission season, even for India, I mean, we see other problem, vector-borne disease like dengue, which are there. So, how do convince countries for elimination? This was one of the questions. If you would like to address at this point.
yeah,
So,
I,
Visinta,
I
we
think
just started with question. Let Dr. Andrea answer one question, and then we can come back. Sorry for that. Yeah,
okay.
Andrea.
Yeah, it's a good question. Is the business case of malaria elimination, and in the clearly the cost per case averted becomes very high under the elimination settings. The tracking, the measures of control, the sustained efforts becomes very compared to the number of cases very high. However, one has to consider the saving over long term that is gained in terms of then continuing investment in control once the disease will be eliminated. And there is a lot of literature on the cost of malaria, not only the interventions, but the inherent cost related to loss of productivity, loss of absenteeism from school, from work, and the cost to the health services. So it's not just the cost of continuing the intervention. There are the costs directly that are generated by malaria. And one comparing both, there is a gain over long term that is obtained by investing in malaria. But clearly is a hard sell compared to many other competing priorities. So it's a good
Yeah,
question. Thank you.
definitely. Thank you, Andrea. So, sorry, Dr. Jacinta, please, you can start your presentation from
Y-
where
y-
you stopped. Yeah,
I'm so sorry about it. So
no
it looks like when it was so critical that my internet failed. Can you
problem.
see
We,
can you see my
yeah,
slides?
we can see.
Yeah. Yeah, so
Yes.
I was saying, in fact, regarding India, of course, there is this presentation by my colleague Tanuja, and so she will be alluding to it quickly to tell about the real paradox that is there that we have in our system or in our region. On one hand, we have countries which are having large populous countries, very large geographical areas like India, Bangladesh, and then which are still accelerating towards malaria elimination. And then on the other hand, we have countries like those that are in elimination and then those that are in prevention of re-establishment of malaria. So what we see is, of course, we know this when malaria declines, we know that transmission is going to get concentrated into hard to reach populations and settings, and it will be mainly seen in forest going communities, tribal or nomadic populations, migrant workers, like in the case of Nepal, then border populations, as it was seen in Timor-Leste as well as in Bhutan, and then which basically demands that there has to be tailored solutions uh, beyond the standard models that we would have, which means we would need tailored tools and delivery models adapted to specific local contexts. And then this is where, in fact, the framework for malaria elimination that was launched by WHO in 2017, the guidance that was available from the framework becomes extremely important, and where this is seen as the different intervention packages that has to be introduced along malaria transmission continuum. I'm not going to go into the details as such, but this image is the most important graphic for us to understand how we have to ultimately focus in different settings, different epidemiological, ecological conditions as to what kind of package has to be there in terms of the method mix and so on. And therefore, I would invite all of you to specifically look into this aspect. Because of the time, I'm not going to go into details. Now, there was this question also that had been asked in the chat box. What are the kind of threats to elimination in the Southeast Asia region? Of course, this has been almost all of them have been mentioned in uh, in Andrea's presentation. So these are not new things as such. However, the gravity of the problems are different when it comes to our region. Now, we know that it's a convergence of biological, operational, and structural challenges that we will have to address at the same time. We know that when it comes to IVAX predominance, our region is having more than 50% of the burden is from BIVAX, which has specific challenges for us. But The radical cure would require G6PD testing, and then we know that the reach of it, the expansion is much more desired, and so on. And then Andrea mentioned about the gene deletions, the Nolisa emergence that is there mainly in Malaysia, Indonesia, Thailand, which is spreading to the other countries as well. Insecticide resistance, Stevens-I expansion, then of course climate variability, the how the vector is getting expanded to high altitudes and also extending transmission seasons, anti-malarial drug resistance, and Andrea alluded to that. But then there are two if I were to talk about the two main drivers or the threats in our region, I would then simply talk about the funding collapse and the conflicts and displacement. Now, I mentioned about the Myanmar cases increasing, and then knowing that ultimately the Greater Mekong sub-region being the epicenter for drug resistance sometime earlier, and we know that it's going to be a threat not only to Myanmar per se, but it is a threat to the neighboring countries in the Greater Mekong sub-region as well as the rest of the world. When this situation is allowed to be escalated, the funding collapse, 64% fall in Southeast Asia regional funding from 2015 to 2024. We are among the lowest of all WHO regions when it comes to a per person at risk allocation of funding. And more recently, we see now, probably Dr. Tanu would allude to it as well, starting from next year, whether there will be an allocation from a global fund uh, 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 for the malaria component. The same scenario we see in Timor-Leste now. After the elimination, as if we have punished them for eliminating malaria, they have done everything that is needed, and then they were WHO certified. But starting from next year, there won't be any external funding as such from the global fund. It appears so. It's the issue is that all these multiple threats are converging at the same time, at a time when we should have probably had focused on all our efforts on malaria elimination, and that's the unfortunate scenario. This is going to be my last slide. What must happen now? Of course, taking all these challenges we have been talking about, but for larger countries like India, then also Bangladesh and the other countries which are yet to reach the elimination threshold, we know that subnational elimination is the way to go, tailored to the local situations and then getting the provincial and district ownership in order to achieve. If we talk about India, of course, India can very well achieve it, as although we could see it as a national level, it is going to be a daunting task. We know at the same time that India alone is like about 50 to 60 countries together, which means at a district level or sub-district level, if we really concentrate our efforts, then of course these districts are having number of cases are similar to what we see in Nepal or Bhutan or whatever. It's quite achievable in terms of those numbers. The data-driven precision that is needed, case-based surveillance activities that has to be done, and the response have to be mounted accordingly. Grassroots action and translate political commitment into local impact, in a way increasing the domestic funding, which is the next point, and cross-border collaboration, especially to assist those countries which are so close to elimination, and empowering communities, as we have seen in Bhutan. They are doing it extremely well, how the community is getting involved for malaria elimination. So I'll stop here, just by reminding that if we are talking about a malaria-free Southeast Asia by 2030, of course, we have only 4 years left with us, and therefore the window is extremely narrow. However, the countries which have achieved malaria elimination have shown that there are tools, the existing tools are there to at least, some countries have achieved it, and the tools that are there already are good enough to come closer to elimination if it is really difficult, of course, until the new tools come in. But then we know that with existing tools, it can be achieved with all the evidence that we have. The goal is within our reach. Therefore, ending malaria is something that we have to act now itself. Thank you so much.
Thank you, Rishinta, for that excellent presentation and your clarity of messages. And thanks once again for accepting at very short notice. And thanks to Dr. Suman Rijal, who had accepted the for presenting in this webinar, but he was not well. So thank you. Now, we will have the next presentation from Dr. Tanu Jain, who is Director of National Center for Vector-Borne Diseases in India. And she is also, she has vast administrative as well as clinical experience with being a postgraduate in community medicine, and she has been providing leadership to the national program since 2021, and also overseeing the national strategies for prevention and control of elimination of all the vector-borne diseases in India. And she will be presenting India's scenario for malaria and with special focus on the subnational elimination. India is a vast country with a diverse epidemiology, so subnational elimination also is an important part when we talk about malaria control and elimination in India. Over to you, Dr. Tanu.
So first of all, are my slides visible?
Not
No.
yet.
Okay. I'll share again. Just give me a minute, huh?
Yeah.
I'll try to share.
Yes, we can see it now. Can you put it in the, yeah, right.
I'll again have to share.
Dr. Tanu Jain, we can share your slide from our side.
Is it visible now?
Yes.
No, it was visible, but not now it is seen. Yes.
Okay, I'll just put it in full screen.
Yeah.
Okay, and stop the presenters mode.
Yes.
Yeah, I hope it is all right now.
Yes.
Okay, great. So hello everyone, and thanks to NAVBD and APMEN for organizing this, and thanks to Dr. Neena Valecha for giving me this opportunity to join. Two excellent presenters have gone before me, and probably they have covered a lot of things which we are also struggling with in India. So I think I'll just go ahead with my presentation here. This has already been discussed, but I think we have plateaued, and I do agree with Dr. Risintha that there is a plateau, and that plateau we are also seeing in India. But overall, the Sierra region has done better than the entire globe. So continuing with the Sierra, I think the World Malaria Report recognizes that India has remained a key engine driving this regional progress, fundamentally altering its transmission landscape. So, if you look at India's path towards elimination, so in the last decade, India has been, able to achieve quite a lot of footage. What are you people discussing? Sorry, I'm so sorry. So there is a category shift if you see. So we had almost 10 states in category 3, and which have now reduced, and this is a drastic reduction. The 3 states that are currently in category 3 are actually, kind of going like a cycle. So sometimes they are in category 2 and sometimes they slip into category 3. So we are trying to work on these 3 states. Then category 2 states have also reduced. And if you see, the category 1 states have gone from 15 to 23. And we have a new elimination milestone. 2 states have reported 0 cases. As Dr. Risintha very rightly said, India is huge. And if you look at Bhutan's population, it is 7.5 lakhs. And that is even less than a population of a district in India. And we have close to 750 districts in the country. So definitely it's a massive challenge for us. This is the baseline how we have shifted from the red to green zone, and But this looks very encouraging. But now what we have done is we've gone down to the block level, and we are trying to go down to the village level. And this was also the guidance given to us by the CRO and the WHO colleagues, that you have to go down to the very basic village level activities. So we have the focal kind of a situation now, that is that there are 32 high burden districts, and these 32 high burden districts are having API more than one. And currently we have also calculated based on the number of cases, so more than 500 cases are also reported from another 32 high burden districts. So these are our focus districts, and we are getting in touch with the states and trying to identify within those districts also high burden villages. And good thing is that we have almost 160 districts which have reported zero indigenous cases. And as Dr. Risintha also has shown in his presentation, we are working towards the subnational malaria elimination verification. So this is the graph of malaria cases as they have gone down over a period of time. So the estimates in the global malaria report, World Malaria Report, are a little, in fact, quite different from what the picture we have. But let me assure you that in our case, as Dr. Andrea was talking about, Afghanistan and other countries, wherein the private sector is the first line of treatment. For malaria in India, private sector is not the first line of treatment. It is also there. But our health system at the basic level, that is a primary health center, a sub-center level, it is actually quite robust. And we have provision of anti-malarial drugs, as well as all the RDT kits, as well as slides for malaria microscopy, and availability of good quality microscope right up to the PHC level in majority of our states and districts. So therefore, because malaria is into the far-flung and a little, areas which are which we may classify as low socioeconomic, so they have good access to the primary health system of the country. As well as there is a concept of active surveillance, which ASHA, especially in the villages, and now urban PHCs also have ASHA, which is going to the house to house and then doing active surveillance. So that is also pretty high. And there has been a decrease in the number of cases and decrease in the PF cases as well. API has also declined, but not to our satisfaction. We would have liked for the API to decline further. These are the high burden districts that we are having. So as you can see that we are totally focusing on these high burden districts. And this is the low burden districts which are eligible for subnational malaria elimination. This activity has been kicked off, and this, with the help of the WHO, we've been able to get the dossiers prepared by 65 districts from 5 states and UTs. And these have been approved by the state, and these dossiers have come to us already. Till date, we have just finished 3 visits. So, and now in the coming month, all the 65 districts will be visited within May and June. And then we are working on the draft dossiers from the other districts and states. So this is the year wherein we are aiming to finish all these 160 districts across 23 states and UTs. So we have already talked about the achievements, and one of the things I would like to share with you is that ABER is an all-time high for us. We have been encouraging the states to increase their testing, and so that definitely has helped us in identifying more and more cases. But you can see, despite the ABER increasing steadily from 2020 to 2025, the number of cases have remained quite static. And with IHIP portal now in place, almost out of the 36 states, 28 states are giving us totally paper-free data. And this is a near real-time data that we are getting. So these are the key achievements I think I have already discussed with you here. I will only like to point out one thing, that we are extensively doing the malaria microscopy. And many of our states are, if they have any doubt in the RDT, they are cross-checking with the malaria microscopy. And we have now 41 L1 trained certified trainers in the country, as well as 21 level 2 lab technicians that have been trained with the help of WHO. So these ECAMs we are holding. And this year also we plan to have at least 4 to 5 of such ECAMs, and we will be training our lab technicians to give quality microscopy services. This is our national reference lab, which is situated in the center. But similar labs are situated across the regional offices, and there are 17 regional offices across the country, and they are catering to all the 36 states and districts. And these regional offices are helping us in carrying on these training and also conducting the quality assurance of the microscopy in the country. So cross-checking is also being done in the center as well as in the regional labs, and the states also are doing this cross-checking. So this is the surveillance interventions that we have done. We have gone down to the granular analysis to the village level with district action plans and tailored interventions. The 137 strategy we are definitely following, and 14 days follow-up also we are following. Then real-time monitoring is happening now via IHIP module, and it can generate graphs, datas, and we are now following up with outbreaks. So what we have classified in a village, if there are more than 1 to 2 cases reported within a period of 1 week, then we are labeling it as an outbreak, and we are asking the villages to the districts to respond to the outbreak and submit the reports to us. So that will help us in avoiding piling up of cases in the times to come. So this is the case management, test, track, and treat. So these are the procurements are done centralized at the central level for RDT kits, and they are given to the states, and this is the central procurement. So the states are giving it to the patients free of cost. Similarly, blood slide examination is done at all level. We even give budget for procuring slides and stains to the states, as well as the states fund from their own budget as well. Then real-time follow-up is there, and all the drugs, including artesunate injections and ACT-SP, ACT-AL, chloroquine, primaquine, these are all decentralized, and we provide the drugs. But in addition, the states also procure these drugs, and they are given right up to the subcenter level. These are the integrated vector management activities that are being done. Insecticide spray is being done, and we are also actually doing pre and post IRS survey to see whether the quality IRS spray has been done or not. So as you're all aware, in the past 3 years, we've been facing a little trouble with procuring LLINs. So we have actually requested the states to now go and try and at least have the ITNs in place. But now the good news is we have decentralized this procurement, and now states can do it on their own. So we are looking forward to having more LLINs being used by the state in the coming times, which will be good for us. Insecticide resistance monitoring, I have to thank the ICMR institutes, which are helping us with both IRS monitoring, as well as there's a therapeutic efficacy study which is going on, which will throw more light on the resistance pattern, if any, in the country. So these are the researches which I just talked about, and Dr. Anup is here, and his team has done an excellent work of G6PD point of care testing, and also they have done a work on low dose primaquine for better compliance, and single dose tefnoquine trials are also done with, and we are awaiting go ahead so that we can adopt these measures in our program. And these research studies that are going on, such as household survey, longitudinal studies, and insecticide resistance and therapeutic efficacy studies, they are being done with the support of ICMR, NIMR, and VCRC. I think that was VCRC, the spelling is wrong here. And as Racinta pointed out, yes, I need to share with you that this was the last cycle of Global Fund, and we had a discussion with the Global Fund team today. So there will be no more funding for malaria from Global Fund. So we have to transition to the activities that the Global Fund was doing with us. And but I'm not much concerned about it. We should have a seamless transition. We had a good discussion with the Global Fund team, and we should be able to transition into a systematic way out of the Global Fund funding activities. Then very rightly said, sustained vigilance is really required. History and recent signals underscore need for continued focus, and this was presented by everyone. So I mean, if it takes so much of time to get 12 cases or 1 cases to come down to 0, so it is not really a very easy task. It's a daunting task ahead of us, and any kind of resurgence can happen. India itself has in the history an example that we in the 1960s and 70s we thought that we will be able to eliminate malaria, but here we are still sitting with that. One of our state, Nagaland, had done excellent in the field of having 0 indigenous cases, and some of the districts, suddenly they started reporting, because as Dr. Andrea also said and Dr. Risinta also said, the whole mindset about elimination is not there, because in our country we are having focal transmission. The cases are not serious, and there are not many deaths happening. I showed you around 55 deaths in the full country, which is reported to us. So people are really not thinking of it as a priority. Rather, for them, NCDs, cancers, dengue, these are the priority diseases. So it is very difficult to get the policymakers give you full, and then that is reflected globally as well. So this is our action plan, which I have really discussed with you already, so I'll not go through it once again. But this is something which I really wanted to tell, because this is something I have seen in the field. When we go, we realize that the policy, I mean the policy makers, they feel that there are pressing commitments. So why is malaria elimination a priority? So those questions need to be answered, and we definitely need to tell them that there is a return on investment. We have invested so far so much on the disease, and we can't afford to have the disease researched in our country, because migration in the within the country, the migration is really not a something we even consider it as a migration. It is just people moving from one district or one town to another town, and they carry with them the disease. So this is all from my side. Thank you very much.
Thank you very much, Dr. Jain. And we know, I mean, India is a large country and such diverse epidemiology. It's at subnational level, one has to have different strategies, and also the other issues related to funding and access and logistics. You have covered it all. So let us start with questions. So the one very interesting thing, Risinta, are you there? Can you have your video on, please?
Yes, I'm pretty much there.
Yeah. So there was one question. What is difference between subnational tailoring and subnational elimination? I found it really interesting. I thought, let me raise it. And then we can, of course, I'll come to the other questions.
Sure. Yeah. So we all know about the elimination definition, and then when we talk about the elimination, we are talking about when the WHO talks about elimination, we are talking about a country or a national level elimination, and when it comes to even WHO certification, we don't consider, let's say, parts of India to be certified as malaria free by the WHO. It's the entire country which should be has to be indigenous malaria free to be considered for WHO certification. So when it comes to subnational elimination, that is basically for the countries which are large and then which cannot achieve the elimination. Did they basically did it at a let's say district level, then they went to the state level and so on, and thereafter they achieved it for the entire country. So it was a process for larger countries, and therefore it's very much relevant to countries like Indonesia, where more than 95% of the entire country. Well, of course, we know that Indonesia has more than 18,000 islands, which means it is very relevant for subnational elimination. So the same applies for India. Looking at the variability that is there, India is so close to, or even there are, as Dr. Thanu said, Nagaland, which had kind of eliminated malaria. So there are situations where you have very high burden as well as very low levels of transmission or no transmission, which means subnational elimination becomes very relevant. In contrast, what is said by subnational tailoring is basically that you use your epidemiological context, ecological context, and other factors to tailor your response. That is the pathway towards subnational elimination. So basically, subnational tailoring is your approach, and the achievement or the outcome would be the subnational elimination.
Thank you very much, Risinta. So, I would like to apologize that we won't be able to take all the questions, but I am trying to pick and choose few questions which seem to me as important. Of course, all are important, and others maybe they have been answered in the chat. So, Dr. Tanu, of course, in India, very this is really relevant question, but I'm sure you have. I've seen in your presentation also you have already mentioned, but still, since the question has been raised and it is important, so they related to the northeast and also some of the high district areas in districts with high transmission. The question is that what are the strategies which you are taking up, and what are the primary challenges, why it is happening that some of the districts are having very high burden, and also in northeastern region there are some challenges. So what are these, and how are you handling that? I'm sure some of it you have already
Right. So
discussed,
I
but
think
yeah.
here what I can say is that even in Northeast there are different challenges in different states and different districts and even maybe different villages. So there are different kind of challenges which are there. But one of the most important thing is that once the cases started happening in the community, then the outbreak response that needs to be really good. And if that outbreak response is good and we really are able to cut out the transmission early in the phase, then definitely we can control, which is not up to the mark currently, which we are working on. Another important thing is treatment completion. So that may or may not be happening in some of the areas. And for that, we are really, heavily trying to, emphasize that treatment completion of 14 days for Vivax, because that is something which we have found lacking, and sometimes it is not happening despite best of our efforts. Because compliance, even, when if somebody tells me to take a medicine for 14 days, sometimes when I'm feeling better, I will stop myself. So to, really get to that level to make the community understand the importance of 14 days treatment. And of course we are looking forward to the G6PD, because these are the tribal areas where sometimes there is a fear of giving primacoin without a G6PD testing. So these are the 2 3 things that I think are important. We've not had drug stock out, so that those drugs and diagnostic facilities are available. Then in sometimes there are areas which are cut out during the monsoon period, so we have implemented our strategy. We are making sure that all the drugs and diagnostics are stocked well before the monsoon season. So hopefully we'll be seeing a lot of activities. Then through the global fund budget also, we have placed now almost at 7 states we have placed NGSRs. So these NGSRs have hired community health volunteers, which will be supplementing the work of ASHA. As one of the participant has also asked that ASHA is overburdened, so what are you going to do about it? Because ASHA is not only looking after malaria, she's looking after at least 22 to 26 programs. So in those areas where the ASHA is, few ASHA are there or no ASHAs are there, through the NGOSR, through Global Fund support, we have placed community health workers, and they have been trained to do RDTs and malaria microscopy. So these things really will help us in bringing down those burden which we are seeing in very local and focal areas.
Thanks. In fact, you already mentioned there was also a question on overburden of community health workers. They are looking after so many other, yeah, definitely. But we have to, have a balance, because these are the actually our contact points with the community, and they have to the deal with. And for malaria, I think having RDT and the community worker giving the medicine, that has really helped us, so far. So one more, when I talk the issue of course, this private sector, even there was a question for Andrea as well. So now with the new steps program has taken in India, do you think it will be better capturing from the information or the data or the number of cases from the private sector as well, now with you have new IHIP launch and other things, or has it improved in your what do you think during this time in last few years, the information from the private sector?
So this is the question for me or Dr. Andrea?
No,
For
I'm,
me?
I'm, yeah, because this doctor, it was to Dr. Andrea also, which he already answered, I think, in the question, but I'm especially referring to India condition
So
because
now, so I'll just go by saying that when I joined the program, then I had a meeting with the Indian Medical Association, which is looking after and issuing directions to the private sector to report cases. So the first thing they asked me is how we report. So now they have a platform. So when we go to a private hospital, we see they are able to put that data in the HIP portal, which is not only a portal for reporting malaria, it is reporting dengue, chikungunya, JE. Even Kalazar was there from 2015, but even during MDA, all the MDA drugs which is distributed, all that data is also entered online in real time. So that is there, and almost this year we have almost 3% of the cases reported by the private sector. So we have the private sectors and the private labs which are roped in, and almost 32 of our states are having this as a notifiable disease. So it is mandatory for them to report even at the private sector level. Yeah.
Thanks, because all said and done, many places these they are the first point of contact, and unless we capture that information, it really
Yes.
we won't get the exact case load.
Right.
And although you replied in the chat box, would you like to add anything on this aspect? Because I remember there was a consultation also on this once, and then all the time we have been saying that this private sector is a critical component, and sometimes even the treatment part as well as diagnostics, these all implementation of that also in private sectors, and the formal and informal private sector is also there, so that becomes a challenge. So anything you would like to highlight on this aspect?
Thank you so much. First, it's very heterogeneous. It's not one block. And in many countries, the private sector is highly demedicalized. It means that pharmacists, sometimes they even give diagnostics and treatment, or there could be also registered drug providers and the big group of unregistered, illegal. So what I mentioned in my reply was that we have now a survey methodology which is called ACT Watch Lite. It was done by Population Service International. It's available, and the methodology can be downloaded on WHO website. It provides like a cross-sectional snapshot on all levels, from the basically importers, wholesalers, distributors, pharmacies, and different levels. And this may be good to just get if it's not available already, a clear understanding of where are the malaria medicines, what are they in terms of also what is being registered or not in the country, and what is available in terms of diagnostics. And that should be really the basis to then develop a national plan for engaging the private sector. And there is a lot of solutions that each country can develop on their own, specific to the situation that they have. Thank you.
Thanks, Andrea. So I'll come to that at the end. I have a one common question for all the speakers, but before that, Risinta, I have like we have a policy of SMC and prevention of malaria in pregnancy globally in the guidelines. So in Southeast Asia, I don't think in most of the countries we have these options. Of course they are for very high transmission areas like Africa, but what do you would you like to comment on this aspect? There was a question also, but I think this is a subject which you could comment on.
Yeah, sure, Dr. Nina. Well, true that we have not utilized these tools in our region simply because these tools that have been mainly used in African continent, uh, the epidemiological context as well as the healthcare services in our region had not been geared towards using this kind of intervention. Now, for example, I was talking about, yeah, let's take the example of India. Now, we know that when it comes to the relevance of SMC over there, as Dr. Thanu said, India has a system where you can reach the population, which means there are alternative ways of handling it. It's a case of ultimately expanding it to the level that ultimately which really accelerates the transmission is interrupted and so on. And therefore what we see in our region, even in the places like Bandarban, where majority of all the cases are reported over there, you need to have a system that is geared towards ultimately doing the SMC and then thereafter having a proper monitoring of all the activities and so on. And why these pockets are having all these cases are due to other reasons as well, where even the SMCs may not be the right answer to those settings. Therefore, it has to be really tailored to the situation over there, and then looking at where the gaps are. Is it a, when it comes to the gaps, is it a vector control gap that is there? Is it the essential services in terms of diagnosis that is there? And then addressing those issues rather than going there and doing mass drug administrations or SMCs and so on, then coming back, allowing it to get re-established after some time. But Andrea is there. Andrea could also, surely he can come in and then probably provide further details and guidance.
Yeah,
Yeah,
please.
this is, again, if we talk about all three interventions, they are very specific to areas where you have a very high level of inoculations. So the medicines that we use in all three settings actually is mainly based on sulfadoxine pyrimethamine. So also they depend on the sensitivity of falciparum to SP. In case of seasonal malaria, is also amodiaquine is added. So again, another drug that in many settings is no longer effective. So it's a question, again, a combination of what is effective and what is relevant considering the intensity of malaria transmission. Otherwise, let's say, suppose giving SP in India for pregnant women, maybe the drug may be partially effective. Maybe a pregnant woman may not even have the risk of several infections of malaria during her pregnancy. And so she will take maybe a medicines 4 times, 5 times during pregnancy, which is not needed. And if it's taken in the wrong time, for instance, the first trimester, it may give malformation to the newborn. So again, is always a matter of risk and benefits, or when we introduce a new intervention, which should be really appropriate to the local situations. And as Dr. Rosita said, clearly these are not at the moment recommended outside Africa. Probably Papua New Guinea, some settings may be relevant, but it's very, very limited outside Africa. Thank you.
Yeah, thanks. I mean, I think the point you mentioned, it's always we have to know weigh the balance between risk and the benefit, because any medicine, especially in pregnancy or even in children, won't be without any risk. And in areas where you have both Vivex and falciparum infection, that again poses a challenge. If you are giving a SMC with SP based medicines, whether that will be effective for Vivex or not. So many issues, but yes, it and it is very high transmission, and there are deaths. Definitely then taking a risk for long term administration in prophylaxis is worthwhile. Yeah. So, coming to, so I had a question for all three of you. Let me start with Andrea. So maybe you have been asked this question many times, but we know technology is now transforming everything, including public health, and we are talking of AI, and digital health and all that for every disease or every aspect of life. So, what do you think, and how do you think this the role of AI or digital health for, especially for malaria surveillance and the response? So, we would like to talk global and regional, and then from India. Over to you,
Yeah.
Andrea.
Over just some immediate applications which are already transferring to technology is around diagnostics. And I would say digital microscopy by some companies is already a very clear applications where there is machine learning on a series of photo libraries, micro photo libraries, of course, and which is very promising, even not only for the performance, but the type of support, like unstained slide to be looked at, and the price of this equipment, which is coming down around $1,000, which is again for something which is still I would say, emerging as a technology is very promising, because we all know how precious is microscopy, but also how demanding it is to maintain the competence, and it's a very more becomes even more precious and more expensive the less malaria we have in any setting. So that is maybe a quick one. And I mean, there could be many, many, many others applications, but this is just want to give you one which we may see actually in the next 5 years coming up. Thank you.
Thank you, Andrea. Risinta, especially, I mean, when we are talking about surveillance and
That's
other
right.
elements, yeah.
Yeah, very relevant, Adal. So just wanted to show the that dimension here. Of course, we have seen when it comes to malaria elimination, how critical the timely response is. And then also we see that when it comes to capacity building, what is required in especially in large countries. Therefore, I see the technology becoming very promising in terms of capacity building at different levels, going down to the level of grassroots level. AI could be really helping. The tools could be really helping in improving their capacity. The second thing is, like all of us have been talking about, whether it is 137 or 135 or 123 or whatever, when it comes to the response. Now, for the decision making, AI tools can be really utilized at that level, lower levels, for the decisions to be taken, which would then reduce the time that would be spent for the reaction time or the response time, thereby minimizing the onward transmission from there. So it's going to be quite promising.
Dr. Tanu, yeah. So,
So,
India leads in this aspect, and we have seen in COVID and otherwise also these technologies. So, what do you think would be the best use in when it comes to malaria or elimination or maybe surveillance or data capture analysis or anything? What is your opinion about it?
So, Dr. Valecha, I think already Dr. Andrea and Risinta have given us details of what are the available tools currently for malaria. For other diseases, yes, of course, there are a lot of things that are being done through AI. But for malaria, there is a limited kind of a thing. We can think about capacity building, we can think about surveillance, we can think about malaria microscopy. So, those are the areas which are there. But I think I'm not a big fan of AI. I'm a big fan of HI. So human intelligence, I feel, is more important, and we want to preserve that brain of ours. So we don't want to make our doctors too much dependent on AI for diagnosis. But yes, at places it is required, at the very peripheries where people don't have that capacity, and that is why we are increasing our microscopy skills. We are not letting it die, despite having very good sensitivity specificity kits that are available with us. But yes, of course, if it is required and where it is required and exactly what purpose, and if it really gives us that result that we are looking for, we are open to AI. In fact, even for breeding places and all, there are very many projects that ICMR intramural projects that have been given. The drones are being used to find out those places where breeding is happening, where you can't go really, and then you can take actions by spraying insecticides. And also there are many research projects which aims is which VCRC and NIMR are doing, and also I think they are working on the microscopy part as well. So anything is most welcome, but with conscious efforts, not to be just spread out across the country, but with definite planning. AI can be used definitely.
Yeah, thanks. I mean, you are very right. All these technologies, also human brain has been used for that. And yes, for vectors and sometimes, integrating the temperature or other climatic data and with the other things so you can predict. So those things have already been used. And yes, we can, of course,
Yes,
that.
modeling we can think of prediction models. So if they can give us a 2 weeks prediction that these are the places which are prone, so we are working with IIT Mumbai on various predictive models as well. So though we are looking at everything, but yes, of course, we are guarded to apply and this thing. But we are definitely looking at everything with open mind, and many of the tools we are using AI tools continuously. Thank you.
Thank you. Thank you very much for that perspective. So I think we are near the end of seminar. I mean, it's time. So thank you all for joining us, and despite your busy schedules, and of course, we got really the global, regional, and the country picture related to different topics in malaria. And on the fight for malaria, we know is far from over. And although we have elimination in some countries or within the countries, but still there are high transmission areas, and even globally we can see the deaths are also there. But we have, definitely you will agree with me, more knowledge, more tools, new tools are also coming up in the pipeline. So let us keep this momentum alive with renewed determination. And rightly so, the theme this time is now we can and now we must. So I would again like to thank our expert panel for the sharing their valuable experiences. And we had more than 400 participants. So thanks to all for engaging in the active participation. And we will be having a poll. You can answer the poll by while we are closing. And definitely all this type of deliberations do help. We can't have in-person meetings very often, but this is a really good medium. This is also technology which we are using, a good medium for discussion and deliberations. Thank you once again to all of you. Thank you.
Thank you very much.
Thank you, everyone. Bye bye. Thank
Thank
you.
you.
Thank you,
Thank
Dr. Nina.
you. Thank
Thank
you.
you.